The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. Today's podcast will be on special needs plans, growth, and risks. Notwithstanding the huge meltdown in health insurance generally, and Medicare Advantage specifically, MA plans are busy making new investments in the program, prognosticating that investments in special needs plans will pay huge dividends. But health plan executives also need to understand the coming scrutiny and operational risks. Back in March of this year, I wrote a detailed blog on everything SNP, from what they are, the types of SNPs, their history, the growth, the regulation, and more. You can go to the blog tab of healthcarelabyrinth.com and go to the March 24th, 2025 blog. This podcast is based on my September 25th and September 29th blogs that can be found at the same tab of my website. We will take 3 breaks today to break this up a bit, so let's get right into it. Plans have been investing heavily in SNPs for several years now, and this occurred even with the financial woes many plans saw in 2024 that led to a massive retrenchment in terms of geographies, products, and benefits in plan year 2025. In 2025, as many mainstream MA products were contracting, SNP plans continued to see growth. In essence, plans doubled down on SNP investments. Indeed, while individual MA plan offerings declined by about 6.5% in 2025, SNP offerings increased 8.5% at the same time. The investments in SNPs have paid handsomely, at least in enrollment. First, from January 2020 to September 2025, SNPs grew from 3.687 million to 7.909 million, a growth of 4.222 million, or about 115%. As explosive as growth has been for MA in general, SNP growth is about 150% more than MA overall, or well more than double. SNP enrollment grew about 264,000 in the 2025 enrollment season and has grown 356,000 since February. SNPs have dominated monthly MA gains in 2025. SNP growth is about 56% of all MA growth from February to September. Third, the only category of SNPs that has lost enrollment is Medicare Medicaid plans, state-federal demonstrations for dual eligibles that are being phased out at the end of this year. Most states are converting these plans into much more integrated SNPs. Fourth, dual eligible or D-SNPs have dominated the numbers, capturing 3.351 million of the 4.222 million growth, or 79% of all growth. D-SNPs grew 118% in the January 2020 to September 2025 timeframe. Chronic care or C-SNPs grew the most from a percentage standpoint in the timeframe, growing by 1 million or 271%. Institutional or I-SNPs have always been much smaller, but have grown by 28% over the timeframe. One important note is that while dual eligible SNPs are mandated to serve dual eligibles, the C-SNPs and I-SNPs by their nature may also have major concentrations of duals as well. With that, we will take our first break, and when we come back, I will tell you why health plans are investing in MA SNPs. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about all things SNPs in this podcast, both growth and risks. We're going to discuss why health plans are investing in them now. You can get all of the details on why plans are investing in the March 24th, 2025 blog I cited above. But here's a quick cheat sheet. First, the Centers for Medicare and Medicaid Services is prioritizing integration of Medicare and Medicaid and reducing dual eligibles costs and increasing quality. Plans do not want to be left out of this growing population. Second, as high as MA revenue is per member, SNP membership offers even greater per member revenue due to various factors in the demographic portion of the rate-setting system, for example, Medicaid status, as well as the clinical risk adjustment component. Dual eligibles and SNP members tend to have multiple disease states. And third, many of the plans are also in Medicaid and see natural synergies between the Medicaid and Medicare lines of business, including the spread of administrative costs. So done right, health plans can reduce costs dramatically against the traditional fee-for-service program cost as long as they practice good clinical oversight and address social determinant barriers. If plans can reduce costs for SNP enrollees, the greater the opportunity for margin. But what about the risks plans could face? I have argued SNPs are not for the faint of heart. There are clearly risks that actually could go well beyond mainstream MA populations. Too few plans think through these issues before they go into the SNP business. So let's talk about a number of those risks. While the system offers great opportunity to gain additional revenue on dual eligibles, the current rate environment shows the risk inherent in the system. Plans need a robust claims and encounter system to ensure accurate and fulsome reporting of qualifying diagnoses to CMS for risk adjustment. It is also true that risk adjustment is being reformed. The new V28 risk model certainly claws back revenue across all MA lives, even the higher revenue dual and SNP lives. The risk adjustment data validation audits that are planned increase risks too. Both V28 and RADV audits will bring down per member per month revenue on all members. If plans do not have the right clinical infrastructure and models, more revenue will not mean more margin. Poorly managed comorbid disease states and social determinants could mean excessive and growing costs on SNP members. There are also several star impacts that are significant. SNPs carry 3 more star measures to manage. While the care for older adult measures have been performing well, some plans are struggling with the SNP care management measure. The huge surge in enrollment is complicating completion of required health risk assessments. More and more penetration of dual eligible and SNP members could lower overall performance. The categorical adjustment index does not adequately offset the impacts on quality achievement for plans with high concentrations of dual and SNP lives. There's also the new Excellent Health Outcomes for All. This is the former Health Equity Index. This is a tall challenge as well because it focuses in on dual eligible and socially determinant impacted population. The more SNP and dual lives you have, it means the harder to achieve significant payouts and rewards from the EHO for all reward factor. A new rule could force plans to have their SNP lives in a freestanding contract. While this could help existing contracts' performance and STAR, it could lower rebates and bonuses on SNP lives, hurting the financial proposition. And most plans are paying too little attention to the emerging and robust SNP program audit protocols. It is a safe bet that CMS will increase audits of plans with SNPs. The audit protocols have become far more severe just in the past few years, and that trend will continue. CMS does not view good clinical management through just the lens of a health risk assessment anymore. They want continual tracking of risks, interventions, and outcomes to drive cost reduction and improve quality. We will talk more about audit protocols in the balance of the podcast. And last, greater and greater integration. The map is already robust in terms of integration, but integration could be added to significantly, and that will impact risk and administrative expense. So, SNPs offer MA plans the ability to improve health outcomes while also registering a healthy margin. But running a SNP product requires superb regulatory and clinical execution, as well as acute sensitivity to the ever-changing integration between Medicaid and Medicare. Is every plan really ready for these significant barriers to success? With that, we will take our second break, and when we come back, we will get into the big risk of program audits. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this edition of the Healthcare Labyrinth Podcast. We're talking all things SNP, the growth as well as the risks. I promised to start a discussion on a very big risk, the evolving program audit regime. Program audits will get tougher and tougher, as I have noted, for special needs plans. This is a big area executives have to be watching out for. They have to be watching for the pitfalls of the growing compliance, regulatory, and program audit environment. So here are a few quick points on the maturing SNP program audit regulatory environment. Program audits are about both meeting Centers for Medicare and Medicaid Services program audit requirements, but as well meeting your filed model of care. For dual eligible SNPs, you also have regulatory requirements within state contracts. These emanate from new rules requiring integration with the state Medicaid program. Integration comes in several forms: loose coordination, more robust coordination, integration, strong integration, and full, or at least near full, integration. In these levels, compliance requirements become tougher and tougher. The audit protocols are still emerging. I remember working with friends at a plan down in Puerto Rico in the mid-2010s who were a bit of a test case on SNP regulation. The plan and a handful of others helped CMS with the emerging program audit requirements in SNP. CMS continues to use forward-looking plans to set their protocols, and each year more and more ideas are tested and eventually will be put into the formal protocols. So what are the emerging trends when it comes to the SNP audit area? Back some time ago, CMS concentrated on whether a health risk assessment was complete and a care plan issued. These two things were very much the focus of CMS's regulatory and audit tests. But CMS has now gone far beyond these simple tests. That is not to say these are not important. They are. A plan can miserably fail an audit without them. But these have now become table stakes in an audit and are very much tested before the audit even begins. CMS is using audits now for far more complex requirements. CMS is now looking at the following. Are care plans issued even if robust outreach fails to reach a member? And do these care plans identify potential problems, goals, and interventions based on what is known about the individual? Do individualized care plans effectively help manage all problems identified in the HRA? Are these goals actionable and remediated in a reasonable time frame? Are there effective interdisciplinary care teams established with ongoing communication of member status, risks, and changes? Are plans identifying risk changes and intervening in care transitions between required HRAs? Are they then reassessing individuals and identifying new problems and interventions? Are successful closeouts of such interventions documented? Is there integration of the SNP clinical oversight process with broader clinical programs at the plan enterprise level? So, where do plans go wrong on program audits? Based on recent audits and other trends identified, here are big areas where plans tend to go wrong. Low HRA completion rates. The latest STAR results seem to show that some lower performing plans are having trouble keeping up with assessment requirements as enrollment grows. Lack of ICPs in individualized care plans and ICTs, interdisciplinary care teams, for every member. Many plans struggle with ICTs given clinical infrastructure. Based on risk, an ICT could be as small as the plan, the member, and primary care provider. For higher risk individuals, a medical specialist, behavioral health provider, or social worker may be added. Focus complex ICTs on the highest risk individuals. Lack of interim assessments and intervention when changes in risk status or care transitions happen. This is a huge issue and a major focus of CMS. Lack of effective documentation of activities, including problems, goals, interventions, and ICT activities. Lack of clear, relevant, and actionable goals and interventions. Not addressing every problem identified during the HRA process, including not focusing on socioeconomic barriers. Member or caregiver input into care plans is missing. This should be documented at the time of the HRA and on an ongoing basis. All SNP plans must provide face-to-face encounters between each enrollee and a member of the enrollee's interdisciplinary care team or the plan's case management and coordination staff on at least an annual basis. With that, we will take our last break, and when we come back, we will discuss some best practices from an audit standpoint. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking all things SNPs, growth and the operational risks and pitfalls. I promise to cover a few best practices before we close out the podcast for the week. A great deal of thought and collaboration across the health plan enterprise goes into effective clinical management over SNP populations. Here are some key best practices for success. Multimodal outreach for HRAs is very key. That will help increase penetration and completion of HRAs. Outreach on as many as 10 occasions on different days and at different times to reach members for assessments is also extremely important. As well, involve providers in obtaining or conducting HRAs. Boost your assessment rates by making sure your care transitions assessment meets all the required HRA domains. Solicit input from the member or caregiver for the care plan. Include prioritization of problems and interventions as well as self-managed and self-directed care when applicable. Ensure all problems identified are addressed in the care plan on a prioritized basis. Even if there is no HRA completed, issue a care plan for every member based on what you know of the member. One goal in the care plan for the unassessed member should be completing an HRA. While the risk of the member should be derived from the HRA, use other methods of risk stratification to identify changes in health status and interventions between required HRAs. Ensure interim assessments are completed in this case. Ensure socioeconomic barriers are discussed in your HRA and problems are addressed. Ensure members' language preferences are considered. Use technology to ensure ICTs receive updates, critical information, and next steps required. Documentation of activities is key. Set reasonable timeframes for fulfillment of interventions and goals. Ensure the SNP activities are integrated with the wide clinical enterprise, including education, care transitions, and related activities. Take credit and document in your SNP case documentation all these activities and engagement of members, no matter how small they may seem. So what's the next frontier in the SNP world? As I said, CMS is constantly refining what they want to see from health plans with regard to SNPs. CMS increasingly is raising what technology-based strategies plans are using to further the overall goals of SNP clinical management excellence. CMS sees the increased use of technology as a dynamic and cost-effective way to identify problems and risks as well as undertake intervention strategies. CMS wants claims encounters, medication history, diagnoses, risk stratification, care gaps, and more used as part of the care plan and clinical intervention strategies. With that, we will conclude this edition of the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.